We're next going to hear from Matt Price, who is the director of the Cardiac Cath Lab at the Scripps Institute in La Jolla. Actually, Matt has decided not to talk about left atrial appendage occlusion. He's more excited about his iWatch, his Apple Watch, and I think he's going to talk about that instead. So,
it's actually called the Apple Watch. It's not called the iWatch.
Okay.
I don't know why it has to. So thanks for having me. Thank you very much. What a great crowded symposium conference we're having today. So my task in the next few minutes is to talk about really a paradigm shift in the way we prevent strokes in the setting of atrial fibrillation. Here are my disclosures. I'm equally conflicted across both pharma and device companies. So hopefully you'll see that in my presentation. So the balance, that is. So what about this link between stroke and atrial fibrillation? It's fascinating. This link has been known for hundreds of years. In fact, the seminal text written by a pharmacist and physician in 1658, Dr. Wepfer, a seminal text on stroke, or what they called apoplexy at the time, stated this: "To this variety of apoplexy, those are most liable who lead an idle life, who are obese, whose face and hands are constantly livid, and whose pulse constantly unequal." So that's not my Apple Watch going off, by the way. Here's something. Okay, it's Dr. Suraj. So here, 400 years ago, identified at that time that atrial fibrillation was associated with stroke. And stroke is a really important contributor of stroke in the United States. In fact, 1 out of 4 individuals between the ages of 80 and 90 who have stroke, it's due to atrial fibrillation. So a large contributor to strokes. And sadly, or ironically, in the United States and across the world, the higher the risk for stroke, the less likely patients are treated with oral anticoagulation. And that might be from a variety of reasons, mostly presumed or actual bleeding risk. There's also problems with pharmaceutical approaches. Warfarin, the well-known drug-drug interactions, drug-diet interactions, having to check INRs, needing to be compliant. And then the NOACs, and we're going to have a NOAC talk later, clearly effective drugs in reducing hemorrhagic and all-cause stroke in patients with AFib, but there's still a bleeding risk and non-adherence. And we have to frame this in this really global epidemic of AFib, because advancing age is one of the primary risk factors for getting AFib. More and more patients have AFib, and this will be more and more of a healthcare issue as we move forward. Well, I mentioned that there's good data for the NOACs and warfarin to reduce thromboembolic stroke in the setting of AFib. The problem is you need to take the medicine to see the efficacy of a drug. And we know from registries and randomized trials that compliance with the oral anticoagulants is quite poor. And this is recent data published earlier last year that nearly 50% of patients who start warfarin over 2 years stop it. And even the NOACs, which are quote unquote easier to take, nearly 1 out of 3 patients discontinue therapy over the ensuing 2 years after beginning the drug. I'm going to go back a slide and forward a slide. Oh, please, play. If you can click that, that'd be great. Thank you. So the bad actor in stroke and AFib is the left atrial appendage. So cadaver studies have shown that more than 90% of stroke-causing thrombus originates in the LAA in non-valvular atrial fibrillation, that is, not in the setting of mitral stenosis. And thromboembolic stroke from AF is more debilitating due to the size of the clots. I mean, that's why we do TE-guided cardioversions. We look for clot in the LAA before we cardiovert. So the question is, instead of either I had a stroke so we're restarting, I guess, here. So in the setting of atrial fibrillation, strokes are larger due to the size of the clots from the left atrial appendage. So the question is, well, why not just get rid of the left atrial appendage? Why should we give a systemic drug? So, excuse me?
Maybe you can control it from the Apple Watch.
Yeah, perhaps. Oh, we're working. Okay, and we have video. Thank you. Well done. Well done. Thumbs up. Thank you very much. So you see here a clot in the left atrial appendage in this gentleman with a high risk for thromboembolism based on risk score. So why not a local therapy for a local problem? And in the United States, there are two available devices to close the left atrial appendage. That's the Watchman device, which is FDA approved for prevention of thromboembolic stroke and left atrial appendage, for atrial fibrillation. And then there's the Lariat, which has a clearance for soft tissue closure. And we'll talk about both of these devices. So the Watchman LA occluder is delivered through the right femoral vein using a transeptal technique. It's available in several sizes. I like to say extra small, small, medium, large, and extra large for various left atrial appendage sizes. It is a nitinol frame with a polyester cap, and its face, that polyester cap, faces the left atrial chamber. You see in the bottom left there a video, a three-dimensional TE of a patient in follow-up who had a Watchman device placed in his left atrial appendage. It seems there's a lag here, so I'm going to go back and forward. There we go. So this is an example of a procedure. I've gone transeptally, and this is TEE guided. I've advanced a delivery sheath that's 14 French into the left atrium over a pigtail catheter, which is in the left atrial appendage. I advance this delivery sheath deep, and I need to get in there deep to deliver this device. And the size of the device, in terms of its width, is the same as its depth. So if you want to deliver a 24 millimeter device, that means you have to get your sheath in at least 24 millimeters deep into the left atrial appendage. So here I am advancing the sheath, and there's these black lines you see on the sheath, which give you a guesstimate about where different size devices would land. So I don't recall this case, but I can tell you now it looks like probably a 27 or 30 millimeter device would land in the appropriate spot. I can tell that just from the lines itself. Here, now what I've done is I will advance the device deep into the appendage and pull back the sheath to allow the device to expand on its own on the left there. It's connected by a cable. I give it a nice tug, make sure there's no leak around the device. I unscrew the cable to release the device fully, and you see on the right side a left atrial angiogram, which shows that the left atrial appendage is fully occluded by this Watchman device. So what is the data for the Watchman device to prevent stroke and atrial fibrillation? So there are 4 studies, 2 of which are randomized clinical trials, 2 of which are continuing access registries, of which more than 2,000 patients have been enrolled with more than 6,000 patient years of follow-up. These randomized trials are in comparison to warfarin. So in warfarin-eligible patients, that's how the FDA framed it more than a decade ago. You got to test this therapy against best of current standard of care, which at the time was Coumadin. In these trials, there was a specific adjunctive pharmacotherapy after the Watchman was implanted. First, after implantation, patients needed to be treated with warfarin and a baby aspirin for approximately 6 weeks, at which time a TE was performed. Everything was fine, no clot, no large leak around the device. Warfarin was stopped. The patient was treated with aspirin and clopidogrel for 5 more months. The clopidogrel was dropped, and daily aspirin was given indefinitely. The recommendation was 325, but 81 milligrams could be given. People say, well, what's the basis for this adjunctive pharmacotherapy? Absolutely zero. This is what it was decided upon based on guess estimate for healing and endothelialization of the device. The PROTECT AF trial has actually now 5-year follow-up. This is the 4-year follow-up published in JAMA. These are patients who are eligible for warfarin at high risk for stroke, who are randomly assigned to either Watchman LA closure or warfarin therapy. And you see here at 5-year follow-up at 60 months, there's a significant reduction in the primary endpoint of stroke, systemic embolism, or cardiovascular unexplained death with the Watchman device. So it's actually superior compared with warfarin. In fact, if you break down the individual endpoints, mortality was lower with the Watchman device than warfarin. On the flip side was safety, driven mostly by bleeding and procedural events. You see that there was an upfront hazard with left atrial appendage closure because you're performing a procedure on a patient versus continuing a medicine. However, there was a catch-up over time, mainly due to bleeding, so that at 5-year follow-up, actually safety was equivalent in both arms. There is a meta-analysis we recently published in JACC, which combined the PROTECT AF trial and the PREVAIL trial, which was a follow-up study that the FDA asked us to do, focused really on safety. And you see here in this meta-analysis, a pooled patient-level meta-analysis, that efficacy between warfarin and Watchman was similar, shorter follow-up time frame with the PREVAIL trial. All stroke or systemic embolism was similar, a significant reduction in hemorrhagic stroke, and a significant reduction in cardiovascular unexplained death. If you look at the event rates in the control arms of the Watchman trials compared to the NOAC trials, it's really impressive. In the PREVAIL trial, the mean CHAD-2 score was 2.6, but the warfarin arm, basically there were no strokes in the warfarin arm, 0.3 per 100 patient years. Now it's a small study, and you look at the 95% credible intervals, wide intervals. This may be one reason, one explanation of why you see the slight numerical disadvantage in ischemic stroke with the Watchman device. Now, if you look at, however, compared to an imputed placebo, and the FDA asked for this data. So what if you look at registry data and so forth, based on your CHADS-VAS score, what is your imputed reduction compared to nothing at all? Significant reductions across the board, consistent with the efficacy of Coumadin. Well, the reason why the PREVAIL trial was performed predominantly was due to the safety hazard that I showed you that was observed in the early part of the PROTECT AF trial. And in fact, the PREVAIL trial had half the safety events as the PROTECT trial, in the setting of more than half the operators being completely new to the device. New operators, safer procedures. And actually, it's even getting lower if you look at the latest CAP2 data, which is the continuing access to PREVAIL registry. And now there's a European data of more, I think it was 1,000 patients called Evolution, even lower rates of safety events during the procedure. Well, what about bleeding, right? The reason why you would put in a Watchman device is not only to get off a drug, but also to reduce bleeding. And we just published an analysis, a pooled patient-level analysis of bleeding events in the PROTECT and PREVAIL trials. And once that 6-month period of adjunctive pharmacology was done, a significant reduction in bleeding events with Watchman. It makes sense. In fact, a 72% relative risk reduction in bleeding. And it didn't really matter what the HAS-BLED score was, what the age of the patient was, what the gender of the patient was. All across the board, a consistent reduction in major bleeding. What are the FDA indications for use? Well, number one, to reduce the risk of thromboembolism from the LAA. Number two, in patients, it's for patients who are recommended for oral anticoagulation, basically a CHADS-VAS score greater than or equal to 2. In patients who are deemed by their physicians to be suitable for warfarin, whatever that means, and have an appropriate rationale to seek a non-pharmacological alternative to warfarin. What's the current status? This is from October of this past year. It was approved in the US in March. Over 13,000 patients have been implanted worldwide. Right now, there's about 100 implanting centers in the US, with nearly half having performed more than 10 implants. So what about reimbursement? Well, right now it's a local coverage decision, but CMS made a proposed decision. This is really, everyone's really curious about how we're going to pay for these procedures. So this was the CMS coverage decision, much like the TAVR and MitraClip coverage, that patients must be enrolled in a prospective national registry. There's specific training and institutional requirements. It must be an FDA-approved device. Currently, that's only the Watchman. And patients must have a high CHADS-VAS score and a high HAS-BLED score. I would argue that you get reduced bleeding across the board. That doesn't make much sense. And then they throw in this kicker, a contraindication to warfarin. What did I just say about all the clinical trials that led to the approval? They were all in patients who were suitable for warfarin. In fact, the FDA indication says suitable for warfarin. So I'm confused. So I think what you'll see is that the final decision will clarify things and be in line likely with the FDA indication. Just 2 more slides about the lariat procedure. So this is a transcatheter ligation of the left atrial appendage through a combined subxiphoid and transeptal approach. And it's really neat. There's no randomized trials. We don't know about the efficacy. We did do a multi-center retrospective registry, which showed that the complication rate was not low with this device. There are questions. About 1 out of 5 patients do have a central leak, which can be plugged. I call this assisted left atrial appendage closure. People say, well, there's nothing left behind. Well, then I don't have to give any medicines afterwards. Well, I would argue that's not the case. I have seen, and there are reports of LA thrombus after the lariat. The FDA has a warning that you should balance very carefully the safety and efficacy of other other implantation approaches, and that the lariat has not been examined closely and has not been evaluated for LA closure. So in summary then, Watchman LA closure is FDA indicated to reduce thromboembolism from the left atrial appendage in patients suitable for warfarin with an appropriate rationale. The proposed national coverage decision is a first step, but problematic if not devised. I think it's a very exciting space for device development, but the future of LA closure will depend on the final national coverage decision wording. And I didn't really talk about quality of life, but I can leave it with this picture. It's one of my patients who actually made this T-shirt himself and distributes it to his friends. So my heart belongs to a Watchman, and so does his. Thank you very much.